The institution carries a lot of that burden of mistrust through history. And those institutions, especially if they haven't been embedded into the community, really do have a upward struggle to try and build trust. Patient doctor or patient provider relationship, do they distrust that individual? Not so much. They more distrust the institution that that individual represents.
So, the causes of medical mistrust are multifactorial. There are things that have happened historically, centuries ago, decades ago, yesterday, that really can impact how individuals and communities feel about the medical system.
My mother also was a double cancer survivor, eventually passed from lung cancer. She had a very negative experience with a surgeon. And my brothers and I had real challenges with this surgeon.
My grandmother, when she was talking to me about growing up, she remembers a lot of the mistrust that happened when she was younger, and she conveyed that to me. Henrietta Lacks and Tuskegee are more current for her than for me, but she taught me that to have a healthy level of mistrust.
Dr. Sims, who was a gynecologist, who developed many of the tools that are still being used in surgeries today, but who did those initial surgeries on slaves, on Black women, without anesthesia. Can you imagine the pain that was endured by those individuals, perhaps the screams that the family outside may have heard?
A lot of people think medical mistrust is about history. History is important, but it doesn't discount what people experience today and what is going on currently. Because never in any time, including today, have people of diverse ethnicities and races receive the same care as the majority. And that is happening today.
We do need to talk about the fact that racism still exists, but we also need to make sure that we are thinking about the healthcare system as a way that really can help to be a balm, to really think as providers, what are the ways that we can meet people, to see people, to be humble enough to say, who is this person who's sitting in front of me?
Now, if I see a patient who doesn't engage, who, when I ask if there are any questions, that they are despondent, don't have any questions, don't have eye contact with us, then I know something's off. I know that something's different, and that could very well be mistrust. And so I ask questions. I will ask, tell me what you know about your disease. Tell me what are your prior experiences at this institution with you and your family, and have those experiences been bad, and what can we do to make it better? What do you need to feel comfortable in the clinic? Because when you have that relationship with your doctor and patient, it has to be comfortable. If you don't ask that question, you're not going to know. And then that barrier, that drift will continue between you and your patient, and you may never get there. So the important thing is to be curious, be empathetic, and validate what they have to say.
Eye-to-eye contact, and I was brought up this way, is extremely important when you're talking to, in particular, a physician who is charged with caring for your body, which also leads to your mental, emotional, psyche, etc. So that was extremely important for me. That's where, I don't know if it was a miracle or not, but it was successful For me, not once could I ever say that I didn't have great physicians.
The Meharry Vanderbilt Alliance is a 20-plus year partnership between Meharry Medical College, which is one of the United States' 4 historically black institutions that have medical schools attached to them, and Vanderbilt University Medical Center. They struck this partnership to really find ways to not only support the educational mission of each institution, to ensure that the best of both of those institutions were being leveraged, but more importantly, to really help to serve the community with a focus on community engagement and working with a variety of different communities to find out what their needs are. So it's really important for the Meharry Vanderbilt Alliance to be there in the community, building those relationships, spending the time so that we can meet people where they are.
The medical school, instead of building a massive university hospital, really at its foundation decided to go out into the community, to spread the medical school at community hospitals throughout the state of Michigan and actually, beyond now, and have students have the opportunity to meet and see people in their communities. And so instead of centralizing medical education and centralizing care, the institution is built to decentralize, be out in the community, that you know your doctor and the doctor knows you, and you have a history and you have a legacy that then just dissolves those barriers down. Just the past 5 to 10 years, where again, the institutions have recognized that there is a need to have diverse populations in clinical trials. And so now everyone is invested in clinical trials. So how do we bring the people to the clinical trials?
After the experience and diagnosis of prostate cancer, then the advocacy edge hit me like a ton of bricks, in a great way, of course. As a race of people, were locked out of clinical trials by way of the communication, because our people didn't know how to even breach that particular conversation. And now, because of the knowledge window opening up to our people, and what we're saying is that clinical trials and diversity work hand in hand. Now, driving that message is not totally easy. It's very extensive. But we're finding that when we bring the entities, whether they be pharmaceutical reps or doctors, and actually patients who have benefited from clinical trials, people's trust is not waning. It's beginning to take a winning side and a winning edge in this fight against all cancers.
One of the strategies that I used when I was the associate director of the Cancer Center in North Carolina was really thinking about populations that may be impacted by barriers. So when I was there, I established a population health navigation program. One of the first things I did was say, go out in the community, spend time, make sure that you are known. Again, it's that trust building, it's that engagement piece. And we really implemented a program where if a person was coming in to the Cancer Center for the first time, we did a screening 2 weeks in advance. We would give them a call. And we even mentioned that there's going to be a team of individuals talking about the complexity of cancer care. And in fact, they may be offered clinical research as part of their care. For each of those navigated populations, we improved clinical trial enrollment by 50%, 50.
One study that was done a few years ago found that one of the biggest reasons that patients withdrew their consent for a clinical trial is that the doctor didn't want me to be on the clinical trial. Why would they say the doctor didn't want the patient to be on the clinical trial? And it's because that those patients talked to people that they saw higher than the doctor on that trust scale. They talked to a checkout person. They talked to a nurse. When that nurse or that checkout person or the nurse practitioner said, I don't know about any clinical trial, then you have mistrust. And so what you have to do is you have to have everybody in, that everybody understands the need and the desires of the patient, and that it is a team sport. Old institutions, but the doctor, here and then put the nurse here and everything else. In reality, different communities have that flipped differently, where the nurse practitioner or the nurse or the checkout people, especially if the checkout people or if the nurse share the same background, share the same ethnicity, share the same race, they're going to prioritize and trust those people higher than the doctor.
And so, one of the challenges in clinical trials to date has been the lack of inclusive participation. We've not had enough representation of communities of color in clinical trials. And so, how do we make sure and how do we know that every treatment is going to work the same in each population? We think about breast cancer as being one of the most common types of cancer for women. And we know that Black women have a 40% higher risk of dying of breast cancer than any other race or ethnic group. That's a problem. And yet, when we think about the studies that were done in breast cancer to look at the screening and how often you need to screen, fewer than 5% of that population, at that clinical trial, fewer than 5% of that clinical trial was comprised of Black women. And so we saw that the screening recommendations were, you don't need to screen until age 50. But yet we missed all of those Black women who unfortunately are being diagnosed with breast cancer at much younger ages and with much more aggressive disease. So having fewer treatment options is impacting the Black community, and yet this treatment recommendation was made despite the fact that the trial itself was not diverse enough to show that we need to actually have screening for Black women sooner. So it's really important for researchers, for institutions that are doing research, to really make sure they become trustworthy. It's really important to make sure you have a relationship so that individuals will know that you are there for them, that communities will understand that whatever institution you represent, whether it be a small cancer center, a clinic that offers clinical trials, that you are there not just to get something from the community, but to give.